We can spin down a vial of human blood and isolate a single microscopic variable. The PSA test yields one neat, isolated number on a standard lab report. Many patients view this number through a rigid binary lens. A high result indicates cancer, and a low result indicates safety. This interpretation is clinically inaccurate. PSA stands for prostate-specific antigen, a protein synthesized naturally by cells within the prostate. A blood test measures the concentration of this protein in the bloodstream. It does not provide information regarding the biological cause of that concentration. Elevated levels frequently occur in the absence of cancer. Conversely, men can have PSA levels well within the accepted range and still harbor malignant tissue. A single biomarker reading has limited utility on its own. To extract meaning from the result, clinicians must map the data against a broader clinical context. A baseline level of PSA circulating in the blood is standard for healthy men. As men age, the physical volume of the prostate typically expands. This chart maps prostate size against baseline PSA levels. As the tissue expands, the baseline protein output rises in tandem, independent of any oncological changes. For a man in his 40s, the standard clinical referral threshold is triggered when levels exceed 2.5 nanograms per milliliter. By his 50s, that same referral threshold shifts to 3.5. In his 60s, the benchmark reaches 4.5. And for men in their 70s, a baseline of up to 6.5 is often factored into the clinical expectation. Doctors account for this growth by calculating PSA density, comparing the blood concentration directly against the physical volume of the organ. Because a universal, normal number does not exist, age-adjusted baselines are the essential filter for determining if a result warrants follow-up. Even when adjusted for age, PSA concentration remains highly sensitive to temporary biological variables. Elevations are frequently caused by non-cancerous conditions, such as benign enlargement or localized infection. Mechanical stressors can also shed excess protein into the bloodstream. Activities like vigorous cycling or recent ejaculation will cause a temporary spike in the reading. To maintain accuracy, clinical protocols require patients to avoid these specific stressors for 48 hours before a blood draw. While false positives are common, the more significant risk in a binary model is the false negative. Statistics show that 1 in 7 men with a normal PSA level actually has prostate cancer. Roughly 1 in 50 men with normal readings harbor a fast-growing, aggressive variant of the disease. Because the test is sensitive but nonspecific, it serves as an early warning screening trigger rather than a standalone diagnosis. Clinicians weigh the result against specific demographic and genetic risk factors. The statistical variance is significant. Black men and men of mixed Black ethnicity face a 1 in 4 lifetime risk of prostate cancer. For this high-risk group, medical guidelines recommend beginning proactive baseline testing at age 45. A first-degree family history, such as a father or brother with the disease, similarly shifts the timeline for initial screening. Doctors also monitor temporal velocity, the rate of change over several years. A steady upward trend is often more indicative of risk than a single high reading. Demographic risk and historical trends dictate the urgency of any screening result, whether performed in a clinic or via a home test. When a result is flagged as high, what is the standard clinical response? A high reading does not lead directly to a tissue biopsy. The diagnostic pathway is a series of safeguards. The first step following a high result is to rule out temporary biological factors and repeat the test. The physician then applies risk modifiers, evaluating the data alongside the patient's age and family history. This is followed by a physical examination to check for symptoms like urinary urgency or poor flow. If suspicion remains, the patient is referred for specialized imaging, typically an MRI scan. The MRI allows specialists to visualize the prostate tissue before any invasive procedures are considered. If the MRI shows low risk, the patient enters a monitoring phase with a follow-up PSA test in 3 to 6 months. A biopsy is only pursued if the MRI, risk factors, and rising PSA levels collectively point toward a high probability of cancer. The raw PSA number provides the initial data point. By applying structured triage, clinicians integrate a variable metric into a precise medical strategy.